Hi, good afternoon. I'm really honored to be part of this panel today. I do have to let you know that somehow my disclosure slide is missing, but I don't have any disclosures. So I think the concept of tracking outcomes for new technologies is really very timely and really germane to the members of our society. And actually, in doing some research for giving this talk, I found this great quote by Sir Ian Chalmers. I don't know if I'm pronouncing that correct, but the quote is, "Because professionals sometimes do more harm than good when they intervene in the lives of other people, their policies and practices should be informed by rigorous, transparent, up-to-date evaluations." And for those of you who don't know, Sir Ian Chalmers is a British health services researcher, and he's actually the co-founder of the Cochrane collaboration. So in doing research on him, that led me to this finding about this ideal collaboration. So the ideal collaboration is a group of surgeons and researchers. It's mostly a British group, and essentially their mission is to inform surgeons on how to have appropriate methodology and reporting for new outcomes so that patients will have good outcomes and, of course, to avoid harm. The collaboration came up with something called the ideal framework, and the ideal framework essentially sets out those recommendations. And I urge anyone who has interest in this to take a look at the website and some of the publications that they have. It's really quite thoughtful. But essentially, the framework goes through different steps on how this should be done. So, for example, for the idea stage, which is the professional innovation database, that's basically mandating that there's a registry for first in-man interventions with an option for confidentially reporting. Also having pre-registered research programs as part of the registry, and then of course the development and widespread use of agreed reporting standards so that there would be definitions ahead of time so that we would all agree on those. The development stage is essentially the prospective development studies, followed by the exploration phase, which is making sure that every patient that has this new procedure, that the data from that gets recorded systematically. Followed by the assessment phase, which is the development and use of well-designed surgical randomized control studies. And then finally, the long-term monitoring phase, which is probably the ones that we're all most familiar with. That's basically having designed long-term observational studies utilizing the registry so that we could look at safety issues long-term, look at really rare endpoints and so forth. So those are things that we're all very familiar with. So just to use some examples, and of course these have been mentioned before by some of the other speakers, but let's talk about POEM, for example. So this is a paper that just came out in Surgical Endoscopy last year. Basically, it's the International POEM Survey. And it's a snapshot of what the experience with POEM has been so far. This survey was actually, POEM right now is obviously in sort of an exponential growth phase since it first came out. And in 2012, when NOSCAR met, they decided to develop this consensus document. So in order to develop the consensus document, they put out this survey and sent it out to 19 centers that were considered high-volume POEM centers. Now, high-volume POEM centers for purposes of this study was defined as any center, who has done more than 30 POEMs. And this is not just in the United States, this is international. It included the United States, Canada, Asia, and I think that's it. In any case, of the 19 centers that received the survey, 16 of them responded, and of the 16 that responded, most of them said that the data that they had entered was prospectively entered data, although one or two of them actually had retrospective entered data. This just shows the centers, and you can see that the centers are lined up chronologically. So the first center obviously is the Japanese experience, and of all the centers that are included, only 2 of them have obviously very high volume amounts of POEMs, and the rest have much lower than 50. Interestingly, when they sent in the survey, they looked at opinions regarding safeguards and accreditation, and you can see that there's very wide variability. So for example, all of the centers uniformly agreed that for first human first human trials that they should be proctoring, and then most of the centers agreed that there should be some sort of preclinical training. But for example, whether or not IRB should be maintained, or whether or not the center should have centers of accreditation similar to bariatric surgery, or whether individuals should have specific accreditation similar to robotic surgery, or either whether or not there should be mandatory reporting of adverse events, that those were all very varied as far as what centers believed. So in addition to the adverse events, we also looked in that survey at whether or not there was any sort of uniformity as far as actual technique, even just positioning of the patient, or post-operative care, and that all was very widely variable as well. Another along a similar vein is the EuroNotes trial. So the EuroNotes, again, this was again just recently published last year. It's basically an activity report of a European study looking at all of the natural orifice surgery done mostly in Europe. The EuroNotes is basically, it's a clinical registry. It's a database that allows for the monitoring and safe introduction of notes. It's a completely voluntary database, but it does allow the participants who are members of the database to have some pretty nice benefits. So basically, all the members of the European Society for Gastrointestinal and Endoscopy and the European Association of Endoscopic Surgery were requested to participate. We don't really know how many of them actually did participate, but the data can be entered retrospectively onto this website. It stores the data anonymously, and anyone who's registered in the database can actually have access to the entire database and look at this. So that's sort of a nice way to look at monitoring outcomes. Of course, there is not any of that being done regularly in any case in the United States at this point. I think probably one of the best examples of a really well thought out and probably the gold standard for databases is the Society of Thoracic Surgery database. Now, the STS database was established in 1989, and it was essentially initiated as a quality improvement and patient safety. It includes all adult cardiac, all general thoracic, and congenital heart surgery. It includes quality performance measures, as well as risk and mortality calculators for all the participants that are part of it. Of course, the STS encourages research to be done using their database. So at this point, there's over 100 publications that have been derived from the database. And then just recently, a couple years ago, the STS now also has a public reporting online, primarily at this point for CABG, so that you could report your performance it's mostly mortality after CABG. And as you can see, this is just specifically for cardiac surgery, but for cardiac surgery, about 94% of all adult cardiac surgery centers are participating in the STS database. Now, the STS does require that to have your boards on cardiothoracic surgery, you do have to have a registry that documents all of your patients and all of their outcomes. It doesn't have to be the STS database, but it does have to be some database, and so they do take this very seriously. One of the nice things about the STS database is that it does have these quality performance measures, and these quality performance measures are actually being used. They are endorsed by the National Quality Forum, and there's even many measures that are at least now or will be included in CMS's physician quality reporting system. Some of the things that the thoracic surgery measures they look at things like outcomes measures, so things like mortality after lobectomy for lung cancer, or morbidity and mortality after esophageal cancer, or just really things like process measures, like, for example, how often are you recording the clinical stage and performance status of your patients prior to undergoing some sort of cancer surgery. They also look at structural measures, so, for example, including your national database. For those of you who are not familiar with the National Quality Forum, it's a nonprofit, nonpartisan public service organization, but basically the NQF endorses and reviews and recommends all sorts of standards for healthcare performance measures. And although that's not really the purpose of this talk, I mean, we were all very well aware of how these are now being used for payment and public reporting programs, and by 2017, it's estimated that about 9% of all Medicare payments will be performance-based. So even if you guys don't want to be involved in this, you're going to have to, because it's going to be regulated by the government. Of course, everyone's familiar with the NIST Clip. NIST Clip has been wildly successful, although it's not really the best way to record outcomes specifically for these new innovations. So participation in NIST Clip is voluntary, and many institutions do not participate in NIST Clip. It obviously costs a certain degree of money that not everyone is willing to pay. It only looks at very specific outcomes, and there's no ability, at least at this point, to change the outcomes that they're looking at. And it only also includes a very small sample of your cases, so it doesn't record outcomes for every single case. One of the things that's really one of the downsides for NIST Clip, particularly for surgical innovation, is that it really relies on CPT codes for procedures. So if you're doing a lot of innovative and cool stuff, there's not going to be a CPT code for that, and you're not really going to be able to use NIST Clip to look at your outcomes for those procedures. So basically, in conclusion, I think we all agree, as everyone has said before me, that surgical innovation is necessary and it's ongoing. I mean, you know, if there was no surgical innovation, there would be no heart valves, there would be no organ transplants, things that we all take for granted at this point. As we've heard by our previous speakers, people come into your office and they want the new technology, and if, as you as a physician are not willing to offer them that technology, then you're going to lose your patients and they're going to go elsewhere. So there is an element to that as well. Of course, there's all the ethical issues that we've talked about up to date, potential harm, conflict of interest, the things that we've spoken about before today. And then, of course, as I said, the current healthcare environment with this pay for performance and public reporting, those are all going to tie in and really make all of this really important. Now, one could say that public reporting and reporting your outcomes for innovations could potentially stifle new research. So if you're doing new techniques and you don't have good outcomes, and you can get penalized by the government. So there's those sorts of things to think about as well. I mean, basically, I think our professional societies like SAGES, they really are the ones that are going to have the biggest role in this. I mean, they set the culture, the standards, the norms, guidelines for the current members, for the future surgeons, for training future surgeons. And of course, I think it's going to be very important for SAGES to take a very active role in helping to support monitoring of tracking outcomes and public reporting for all of these new innovations that all of our members are using. Thank you.